acuity. After the eyes, we move on to the ears, looking at the external part of the ears, assessing the pinna. There's no drainage coming from the ears. If you had an otoscope, which I don't, but if you had an otoscope, you could examine the inner canal of the ear, look at the tympanic membrane, make sure that it's not perforated, there's no swelling or drainage in there. And in order to insert the otoscope, you would pull, in an adult, you would pull the pinna up and back and then insert the otoscope. If you don't have an otoscope, you could just use your pin light to kind of look and make sure that they don't have anything in their ears, things like that. So we've done the head, the eyes, the ears. Now we move on to the nose. Again, looking at the outer part of the nose for any asymmetry or lesions. You would want to assess the patency of each nair by occluding one side and have them breathing in. And then to look inside the nose, you could use a speculum to look for any deviated septums. You could check the mucosa, look at their turbinates. But since I don't have a speculum, I'm just going to use my pen light to look up inside, make sure she doesn't have anything up there. It's not supposed to be up there. So then once you've done the nose, you move on to the mouth. And again, looking at the outside first, noting any lesions or sores on the lips or around the mouth. Then you could ask them to open their mouth and look at the inside, looking at the tongue, the gums, the teeth, make sure the mucosa is pink, looking at their tonsils, if your patient has tonsils. Mine doesn't have any tonsils, but if they had tonsils, you would want to grade them. Again, looking at the tongue, the floor of the mouth as well. And then if you had a tongue depressor, you could assess the gag reflex and ask them to stick out their tongue and say ah. So then moving on, from the mouth, you could go down to the neck. So we've done the head, the eyes, the ears, the nose, the mouth, and then you move on to the neck, looking for symmetry. She doesn't have any masses that I can see, no jugular vein distension. So after I've inspected, I would go on to palpate the neck, make sure there's not any tenderness in the neck. I'm looking for the lymph nodes, make sure she doesn't have any swollen lymph nodes. I'd want to palpate her carotid and check the carotid pulse as well. And then you could also want to palpate the thyroid and the trachea. Make sure the trachea is midline, there's no tracheal deviation, and then palpate the thyroid, which is best done from behind like this, posteriorly. Make sure that the patient doesn't have a goiter or anything like that. So after you've done the neck, you can move on to the chest. Oh, another thing with the neck, you could test the shoulders, have them shrug their shoulders against your arm strength, just to make sure they have symmetrical shoulder movements as well. So after you've assessed the neck, you move on to the chest, and you want to look for chest configuration, make sure it's symmetrical, and then you would want to move on to palpating the chest for any masses or nodules, anything like that. Usually I like to start with the anterior chest and then move to the posterior back of the chest. It doesn't have any tenderness or masses, so then you'd want to check your tactile fremitus. And you want to do it over the long apices, because if you do it over bony prominences, you're not going to get that, you're not going to feel that vibration that you want to feel. So I'm going to go ahead and have you say 99.
99, 99, 99, 99.
And that's how you check for the tactile fremitus. And then I would want to percuss, again moving down in a ladder-like fashion whenever you percuss. And you just want to make sure that there's no hyperresonance or dull sounds. anything like that. And then after you percuss, you can go ahead and listen to the breath sounds. And I usually start with the inner third of the clavicle and then work my way down in the same ladder-like fashion. I'll go ahead and have you take a deep breath. And again. And again. And then once you've done all that, you'd want to do the same thing posteriorly. So you'd want to do your tactile firmitus, do your percussion, and also listen to the lung sounds posteriorly. Go ahead and stand up and turn around. So then I would do my lung sounds in the same ladder-like fashion. And I'd also want to go to the out to the side so I could hear lung sounds out here as well. Another thing that you could check posteriorly would be the chest expansion. Make sure it's symmetrical. So you'd want to put your thumbs midway, kind of push in and have the patient take a deep breath. And your thumbs should go out equally, so that means that they have symmetrical chest expansion. Then after that, you go ahead and move on to heart tones. I'm going to listen I'm going to assess the heart tones at the aortic area, the pulmonic area, the tricuspid area, and the mitral area. So aortic is going to be second intercostal space, right sternal border. Pulmonic will be straight across to the second intercostal space, left sternal border, or right sternal border, left sternal border. And then tricuspid is going to be fifth intercostal space, left sternal border, and mitral will be sixth intercostal space, mid-clavicular line. Go ahead and listen. And you'd also want to count the apical pulse for 1 full minute as well. All right, and that concludes our assessment of the head, neck, and thoracic area, and the eyes, ears, nose, and mouth.